Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi. Dear colleagues, I know it's very late in the afternoon. Today I'm going to present a lady. She is 75 years old. She is known to be diabetic, hypertensive, and she had a history of breast cancer 20 years back, and she received the radiotherapy. She also, she's known to have a coronary artery disease. She had a BCI to LAD and OM more than 9 years back. She is complaining of shortness of breath and complaining also of exertional chest pain. Echo revealed a very severe aortic stenosis with mean gradient more than 50, and she has a significant LVH. Left ventricular function is still preserved, and she had a significant pulmonary hypertension. When we try to step back and to see what do we have is in relation to this problem, that the prevalence of aortic stenosis patient or the probability to have a coronary artery disease, it can touch up to 70% of all comers. In the intermediate risk trials, they had a 60% of their patients to have a coronary artery disease. So before going to the Tavi, do we have to do what we have to do for the coronaries? Do we have to do a non-invasive assessment, or we have to do an invasive assessment? So if we look to her anatomy, we see that a non-significant right coronary artery lesions, we have a borderline OM lesion just distal to the initial stent, and she had a mid-calcified distal to the stent, a very tight aortic stenosis, LAD stenosis. And we did an IFR for physiological assessment, and we find that the LAD is in the what we call a positive range, and the IFR to the LCX is still in the gray zone. For these type of patients, what do we have to do? Do we have to go to medical treatment, or what we have to do if we have to do a PCI, when to do the PCI? Where is the evidence? 5,000 patient meta-analysis comparing the patients who had a PCI versus who does not have a PCI, they found no benefit from routine PCI before Tavi. The 30 days MACE or the 1 year mortality does not differ. And the only trial, which is a limited trial, the activation trial, randomly compared as a randomization, the PCI versus non-PCI, it does not prove a non-inferiority. While as 2/3 of these patients had a single vessel disease, and 2/3 of these patients were totally asymptomatic. So it is a bit misleading. Where are the guidelines pointing in this issue? PCI should be considered in patients undergoing Tavi, in patients with a proximal coronary artery disease more than 70%, which is a 2A. Suppose we are going to elect for doing a PCI. Which time we have to do the PCI? Some people say we will combine the PCI and Tavi at the same time. We reserve a single or a much less access intervention. We have a lower cost, we have a shorter hospital stay, less number of hospital admission, but on the expense of a much larger amount of contrast, prolonged procedure, need for dual antiplatelet beforehand, so the risk of bleeding would be higher. If we elect to do the PCI before the Tavi, which is mostly, this is the most of the people, they do that it is easier access. We don't have a problem when accessing the coronaries. It is more or less, we do not have the risk of rapid pacing related ischemic events. We reduce the contrast, but we cannot rely 100% on the physiological assessment, FFR and IFR in borderline lesion. And again, we have a higher risk of hemodynamic instability due to aortic stenosis. After the PCI, it would be simpler, easier, less contrast, but we will face the hassle of inability to access the coronary. So do we have a consensus? Yes. It is better to have the procedure done beforehand, but to me, I wish to categorize the patients as it is completely different patients with associated mitral regurgitation, severe coronary artery disease, impaired left ventricular function, they will be different. So for this lady, we had the Tavi. First, we did 29 valve and we had no mitral regurgitation. We have an easy procedure. But we need to remember that after we put the valve, we need to remember that the commissural alignment is another introduced factor for here, that if we look carefully to these two platforms, we can see if we have the commissural line or the commissural line is facing the coronaries, we will have a significant difficulty in accessing the coronaries. And this is contributed by the commissural alignment and the height or the depth of the valve implantation. And again, we need to remember for every self-expandable valve, we need to make sure that we achieve a commissural alignment, either with the cusp overlap when we have to see the head in the center and in front, and we separate the post 1 and 2 in both accurate new and the Portico valve. This statement to me is very, very important, and it is related to the discussion we had before, that the impact of commissural alignment is very important for coronary access, for coronary artery perfusion, for the leaflet's stress itself to affect the leaflet longevity, and also for the paravalvular leak and the effectiveness of the outer sealing of the skirt, and finally when we have a Tavi in Tavi to be feasible for leaflet laceration or basilica. We brought this lady because we know that she is significantly symptomatizing from the coronary artery aspect of in the form of chest pain. And here the cannulation of the coronary was not an issue. We repeated the physiological assessment. The LAD did not change, and the IFR to the obtuse marginal actually changed. If we look carefully to the re-access trial, as mentioned before, that it's 300 patients before Tavi, it's almost 100% you can cannulate the coronaries, but after Tavi you can lose cannulation of the coronaries up to 4% in the right coronary, and also similar 4% in the left coronary. It is variable between valve and valve. Why we face a problem in this? Either because we don't know very well the aortic root anatomy, and it is related definitely to the design of the prosthesis we had. It is affected significantly by the commissural alignment. It is affected significantly by the height of the implant, the height. If it is significantly higher, we might face a problem. And also it is affected by the old leaflet height and the sinus width, the height of the coronaries, and the STG width and sinus of Valsalva width. When we face this type of patients, usually this is a very interesting article that it gives us an impression when we are trying to cannulate the coronaries, either the closest aligned cell is just opposing the ostium, or it is below the level or above the level. Do we have an interference from the commissure itself, or we have a large gap between the valve frame and the ostium of the coronary? All of this, it will affect the cannulation. Again, the same scenario will face it when we are talking about the valve Tavi in Tavi. We have two different scenarios. First, the prosthesis was a low profile valve, and the second prosthesis will be short or long. This is all our varieties. This is for the sake of time, I will just skip this one. And for this lady, it was not a problem at all to use a cutting balloon, DAS to the LAD and DAS to the obtuse marginal with safe result with no problem. So my take-home message for this presentation, that since coronary artery disease and aortic stenosis often coexists, the evaluation and management of coronary artery disease in Tavi candidates is of paramount importance. With the extension of the procedure to the younger and lower risk patients, invasive coronary angiography remains the mainstay for coronary artery diagnosis. Although the coronary CT angiography can do the job, but this is only limited to the very low risk patients. BCI should be performed in the setting of severe coronary artery disease with the involvement only for the proximal segments or patients with persistent angina, preferably before the implantation of the valve. Selecting the type of the prosthesis for future coronary access is very important. Commissural alignment and the intra-procedural techniques should be routinely adopted to optimize later coronary access. Thank you very much.